So our last talk will be from Brittany and Sanava, who will be discussing pediatric. The time is now for standard approaches to pediatric melanoma. Welcome, Brittany.
Hi, everyone. Thank you for having me. So I am a pediatric oncologist here at the University of Pittsburgh, and I am always honored and humbled to come here for the AIM Symposium every year. Many will first ask me if children get melanoma, and they do, of course, which is why I'm here. And I like to go after everyone else's talks because it's really important to think about, we've heard really fantastic talks from Dr. Najjar and Dr. Davar, and I benefit from all of the work they do. So in the rare chance that I do see a patient that has metastatic melanoma and they're young, the studies have been there, the treatments are available, but we need to take a few steps back. And that's what I hope to highlight today, because as it turns out, children are not little adults, and pediatric melanoma is not little melanoma. So, okay, so this is our overview for today. So first, just to give you a little bit of background about pediatric melanoma, how we classify it, and how we think about treatment. So as you all likely know, there's almost about 100,000 new cases per year of melanoma in the United States. And when we think about the numbers that impact our children, it's just a tiny fraction. So in the 0 to 20 age population, which is the population that I most frequently take care of, we see about 400 new cases of melanoma per year. And important to say that's reported clear melanoma. And I think what I hope to have you walk away from this today is that actually making that diagnosis is really challenging. And so knowing what to do with patients with melanocytic tumors is really challenging. Now, when we push up into our young adult population from 20 to 34 years of age, it starts becoming much more prevalent at about 5% of the overall cases. And then really for young patients, it's the second most common cancer in that age range. And just to also put into context, as a pediatric oncologist, the total number of all pediatric cancers per year in the United States is 15,000. So we see just a fraction of all comers of all different types of cancers, leukemia, melanoma, brain tumors, compared to the overall number of melanoma cases. And that really makes a difference in terms of how we study and how we get the numbers of patients to really make a significant difference, like my colleagues have in research. So unlike older adults where squamous cell, basal cell are far more common, this really is the most common cancer, skin cancer in children. So if we see skin cancer, it typically is melanoma. So how do we classify it? A lot has to do with the biologic behavior. So what is the chance that tumor on a child is going to spread, cause trouble, and need systemic therapy? And so when we think about young patients with melanoma, we usually classify it into three main categories. So one being conventional melanoma, so adult type melanoma. The second being melanoma arising in a congenital nevus. So we have some patients that are born with really large nevi that are covering large portions of their body, and that melanoma is different in how it behaves and how it arises. And then the last is a special category called Spitz or spitzoid melanoma, which adults can get as well, but is far, far more common in children. And this is one of our most challenging subtypes. Despite these subgroups, we know that the behavior still differs from adult melanoma. And so if I have a child walk into my office and they have, conventional adult type melanoma, that doesn't really tell me which child is going to go on to have a more aggressive type of cancer and which child we could maybe back off from the treatment. And interestingly enough, we know that a child that comes in with the exact same stage of conventional melanoma as an adult will generally do better than that compared adult. But again, I don't know how to predict up front, like Dr. Najjar was speaking about, who that child is going to be. And even within the pediatric population, we know that our little kids, so our 0 to 10-year-old patients, they just do better with melanoma than our kids who are in the teen age. Again, we're not exactly sure why. And so this smaller subset of children whose tumors are going to behave like an adult melanoma are really difficult to predict. And you can imagine that these children have long lives to live, and putting them through really large surgeries and potentially toxic therapies can have significant implications if that's truly not needed. And then we get into the population of tumors that is what I see most commonly and is really, really challenging. So we see a lot of tumors that are biopsied, and we get the result that this is an atypical melanocytic neoplasm or tumor. They're typically in the Spitz category or something called MELTUMPS, which is a melanocytic tumor of uncertain malignant potential. And we've made a lot of headway over the past decade in terms of some predictive biomarkers within the tumor that we can say, okay, those tumors usually act more like adult melanoma, those tumors don't. But we're still really not sure about how to integrate those studies up front when a patient has a biopsy. And then likewise, in conventional melanoma, it is very clear that a sentinel lymph node biopsy and the status of your sentinel lymph node, it will appropriately stage you. We can predict your risk for recurrence, and even that does not have the same prognostic utility in these borderline melanocytic tumors. So with all of that, how do we treat our patients? There really is no separate well-defined management strategy for pediatric melanoma. And the surgical excision of melanoma remains the primary treatment modality. And like many patients in the room will know, the size of your excision of that primary tumor is dependent on how thick the tumor was or how deep it had grown into the dermis. Most melanomas are highly curable with surgery alone, which is great. And most of our melanomas that come in are in fact local at diagnosis and amendable to surgery. And so here we have really almost bread and butter for my adult colleagues, the National Comprehensive Cancer Network guidelines that give us evidence-based surgical recommendations for how much surgery needs to be done for a certain thickness tumor. So what does that wide local excision look like? Who should get a sentinel lymph node biopsy and who should get systemic therapy? And this is all supported by robust adult clinical trials, but not necessarily pediatric specific. So how did we arrive here? And I think, this is, it's almost, I don't know how much of my adult colleagues even think about this now, but it's important to think about in the context of children. So how did we arrive at the current recommendations for surgical management of melanoma? And here, we won't go into great detail, but in general, based on the thickness of the tumor, the Breslow thickness, which is depicted below. So either you have a thin melanoma, T1A melanoma, or a really thick melanoma, T4 melanoma. That surgical management, how much skin you need to take off around that tumor is guided by how thick that tumor had grown. And then likewise, that thickness also predicts who will have a positive sentinel lymph node, and that guides your decision on who to do a sentinel lymph node. Again, these are adult recommendations. So what about, thinking of the surgical treatment? How did we arrive here? Well, years ago, prior to the discovery of how important it is, the staging of the primary tumor, that thickness, there was a huge amount of skin taken off. So large surgeries that could have a lot of significant consequences. Then, it became known that the thickness was really important, and the margins of that surgery were scaled back. And in 1980, there was the first prospective trial looking at surgical margins. So we've heard today about how important prospective clinical trials are. They give us the data that we know that guides our treatment of patients today. So this is not by any means to go into detail, but just looking through that there is a lot of historical background for how we treat melanoma. So from 1980 onward and ongoing currently today, there's been multiple trials looking at different amounts of surgical margins, the healthy skin that needs to be taken off around a localized melanoma, and how that impacted patients' OS or overall survival and DFS, disease-free survival. And now, is exciting to see that we're in the current era, we're thinking more too about how this impacts patients. So how does it impact the quality of life, safety, et cetera? And that's something I think about a lot in my young patients. So there's a current clinical trial that's a multi-center trial that's ongoing and looking specifically at surgical margins, and it's currently recruiting patients. And so, this picture here is to show you that that red dot is the tumor in the center. Whenever we say a difference between a 1 centimeter re-excision or a 2 centimeter re-excision, it actually equates to a really significant amount of extra skin that needs to be taken off, because that's the radius margin that's measured. And you can imagine that in a young patient who has far less surface area they have to grow into that body, these surgeries can be really can be very quite morbid. And so currently there's a trial looking at 1 centimeter versus 2 centimeter margins for primary lesion re-excision. Again, this is in adult patients, which is the problem we face in a lot of cases. It's thought that a reduction in margins is going to improve patients' quality of life. If you look at the inclusion and exclusion criteria for this trial, it's for patients 18 years of age and older. So the vast majority of my patients would not be eligible. And the patients that are excluded are the patients that I see. So those patients with uncertain diagnosis of melanoma, i.e. the so-called melanocytic lesion of unknown potential, are excluded. So we're left back to the drawing board with our young patients. So, thinking of what we do in children, and here's a picture to depict that these are large surgeries in young patients, or large surgeries in anyone. But the larger they get, they can be associated with more complex surgeries. They can have issues with wound healing. They can get surgical site infections, be admitted to the hospital for these surgeries. All of the impact that living with that scar for the rest of their life may have on them. And of course, this can decrease overall quality of life. And so the goal is to really improve the care of our patients and the overall experience of our patients without compromising any of their oncology outcomes. And this is all just technically more challenging in our small patients. So when we think about the surgical management of a pediatric melanocytic tumor, there's genuine uncertainty. It's really interesting. In my clinic, I see all patients before their surgery, because our surgeons feel so uncomfortable with making this judgment call on these young patients with melanocytic tumors. They know that they're big surgeries. They know that the margins are important, and there's data to support which margin we choose. But because we don't know exactly how that tumor is going to behave, if it's going to come back, if it's going to cause a problem, the surgeons don't want to do the surgery until they consult with an oncologist and we make a plan. So this, in my clinic, is one of the most difficult decisions that we make. So, what's the surgery going to look like, and are we going to do a sentinel lymph node, and how are we going to interpret it when we get those results back? And so, I'll leave you with an expert consensus statement that can be found that just really sums it up, that an excision margins are tailored to individual cases based on size and depth, and a sentinel lymph node biopsy is not recommended unless a malignant tumor cannot be ruled out, which, again, we don't know how to do that yet. So very challenging. And so we really need prospective data and standard management recommendations for our patients. So how can we do this? And I'm going to take you through a little bit of information about our pediatric consortium called the Children's Oncology Group. So in the field of clinical trials in oncology. We have our National Cancer Institute, or our NCI, and through that we have the National Clinical Trials Network, or NCTN. And these clinical trials are meant to improve the lives of people with cancer by establishing new standards of care and new treatments approaches. So what about in pediatric melanoma? Many patients that are listening to this today might have been on trials through ECOG or SWOG, our adult consortia. And here we are, COG is our pediatric consortia that you wouldn't know about if you didn't take care of kids with cancer. And this is a group that I am incredibly proud to be a part of. So this is the largest organization devoted exclusively to children and adolescent cancer research. It unites over 10,000 of us in over 200 leading children's hospitals and universities across North America, Australia, and New Zealand. More than 90% of kids diagnosed with cancer each year in the United States are cared for at Children's Oncology Group institution, which our institution is. And it really has turned children's cancer from what was virtually incurable 50 years ago to being that over 80% of children diagnosed with cancer will survive. And so this large multi-site structure of COG really allows the conduct of research for very rare childhood cancers, including melanoma. And I think we've learned from our previous talks that we really do need, we all need to come together to really make a difference in these clinical trials. So what has the Children's Oncology Group done for melanoma in the past? So importantly, there's been no prior COG-led melanoma initiative. So that's what we're here to change. In the past, we jumped on some of the ECOG and SWOG trials for kids 12 and older. And these were all trials that used interferon, which is no longer recommended and have been closed to accrual for many years now. And so, now we have over 33 FDA approved drugs for melanoma, not specific to pediatrics, of course. These have all been since the last COG participation in a trial. We know that surgery is still the most important, and so we use these as an adjunct to surgery. And the thought and the reason I'm giving you this history is that it is very hard to make a difference in the field of melanoma in terms of systemic drugs in children, because by the time we get the numbers to have enough data to make a true statistical difference, our adult colleagues probably have moved on to the next really amazing systemic therapy. And so what about looking at a multi-center trial, looking at the surgical management of these patients, because I hope I showed you that it is a really difficult decision to make. So our hypothesis is that a COG-led study of risk-based stratification of the primary surgical management of pediatric patients with atypical or malignant melanocytic tumors, again, because that distinction is really challenging, will be feasible, and it will inform our development and implementation of future larger prospective trials. So I won't get into the nitty gritty of this, but just to take you through, what we are attempting to do is that patients would be seen at a COG site. They might have an oncologist that's really never taken care of melanoma, but that's okay because we have a trial that's designed by people like myself that think about melanoma all the time. Those patients would be enrolled into the clinical trial. Experts in the field of looking at melanoma under the microscope in young children would review that biopsy. If they decided, this actually doesn't look like melanoma or anything atypical, those patients would be observed. If it did look like it was atypical or malignant, we would do more further molecular profiling on them. And the decision about how to decide high risk versus low risk is a topic for a different day, but a lot of work has gone into that. We would say, okay, we think your tumor is high risk. We think it's more likely to behave like a true adult melanoma. You go on to get the standard surgery that an adult would get. And then you patients that don't seem to have high risk tumors will just have a really tiny re-excision, no sentinel lymph node biopsy. And we will observe you to see, to ensure that you don't have a recurrence. And so because the COG has never done this, there's a lot of questions is this feasible? Can we get patients and providers to enroll their patients? How are we going to do this? And so I won't give you, I'll breeze through this next section, but I just think it's really exciting to see that maybe others are becoming as excited about melanoma as I am. And so we went out into the community of providers and said, hey, we are here as a pediatric oncology group. We want to conduct a study looking, trying to centralize the care of these patients so that no child is left behind. And dermatologists and surgeons and pediatric oncologists, what do you think about this? How are you referring your patients? Can you tell us a little bit more? And would you be willing to send your patients to us so that we could work together to improve the care? And so, we first asked our children's oncology group sites, how many new patients with cancer per year do you see? And do you see patients with pigmented melanomas or atypical Spitz tumors? And the answer is yes. So the numbers are there, which was actually surprising to us. We had 70 institutions respond to our survey, and there's about 240 COG institutions. And of those 70, there was a total grand estimate of about 200 to 250 new patients per year being already referred into a children's oncology group site. We next said, well, what are the clinical scenarios prompting referral? Why are you seeing these patients? Why are you consulting with other medical specialties? And by and large, our pediatric surgeons, our pediatric dermatologists, our general dermatologists, and our pediatric oncologists all said that if they get a pathology report back after a skin biopsy that said that a child has melanoma, they're sending them into another subspecialty to help manage that. Likewise, if they're coming back with these atypical Spitz and non-Spitz tumors, which again are really challenging, they're sending them in. And then lastly, if they did a biopsy and there's still some tumor remaining or there's positive histologic margins, they're sending them in, and they're waving the white flag that they need some help from other providers that might know a little bit more about taking care of these patients. Then we asked them, are you interested in a prospective trial? Would you send your patients to us? If we had a trial, could we finally work together to take care of these patients? And the overwhelming majority said absolutely yes. So all of our providers that see these patients up front, the majority said yes. The second answer was maybe, and really very few said no. And when we looked at this data, most patients that said no, we wouldn't send patients, they were typically saying, I also don't take care of these patients, which of course makes sense. And so lastly, we said, okay, well, if you have a patient and you're consulting with another provider and you feel like you're lost, you don't know what to do, are you already thinking about talking to a pediatric oncologist? And most of our providers also said yes. So pediatric surgeons and pediatric dermatologists are typically the doctors and providers that are performing these biopsies of suspicious skin lesions in kids. They said, yes, absolutely. If I'm getting these back, I'm sending to a pediatric oncologist. And so, conclusions here are that our respondents identify that melanoma and atypical melanocytic tumors are challenging and that they need to consult with other specialties. We figured out that there really is complex referral patterns, which I know we see all the time. They're in the hands of many different types of providers, but most of them are still wanting to consult with pediatric oncology in these settings. Patients or providers are interested in a prospective trial, resounding yes. The vast majority said absolutely, we would be interested, we would refer patients, and we would collaborate. And the results of this multidisciplinary survey suggest that these patients are being referred to pediatric oncology. The interest in a trial is strong, and this really is an unmet need, and perhaps can show that a trial of this nature, which would be a big undertaking, is feasible. And then last, I'll leave you with, we're here, we think we can do this. I just actually 2 days ago got back from our Children's Oncology Group national meeting where I proposed this, and it was well received. And so we're going to move forward with trying to get this through. But in the design of this, one of the things that I like to bring up is, patient advocacy is truly essential. So Our high quality clinical care requires our patients to provide information about how they're feeling, their symptoms, and any effects of our prescribed treatment. So in this, it would be in being on a clinical trial, and the prescribed treatment would be their surgery. I mean, how does this impact their life? We know patient-reported outcomes, or we call them PROs, whenever they are embedded into our COG trials. Foundation support, such as AIM, is critically important, and the voice of the patients and families is critically important upfront in the trial design. And so we really do want to hear the impact of diagnosis and treatment from our patients and their families. And with that, I will thank you. Thanks to all of our groups at the COG that have been working hard to put this together. I hope next year when I'm standing up here, I can tell you that it's a good go, and that we're going to be recruiting our first patients. And of course, thank you to all of our patients and families that make this possible.